Thank you for the opportunity to talk, and thanks to the two chair people for the invitation. I've been asked to speak about two birds with one stone. I think the saying is killing two birds with one stone. We'll try not to do that today. The association between BMI and gastroesophageal reflux. I have nothing to disclose. We know that high BMI causes reflux. Panolfino in 2006 proposed multiple causes for this, most of which are pretty obvious. The increased intragastric pressure in the obese people causes increased pressure gradient across the lower esophageal sphincter. It is noted that there's a greater degree of separation of the LES and the crural diaphragm in patients with very high BMI. Decreased gastric emptying occurs, possibly because of diet and possibly because of the pressures as well. There are some papers that suggest increased frequency and number of transient lower esophageal sphincter relaxations, and there is disruption of the esophagogastric junction in the obese as well. We can see the next graph towards the right side that depending on the severity of the obesity, the increasing BMI, the odds ratio or the chance of having reflux symptoms is markedly increased. That graph's identical when one looks at heartburn, regurgitation, or simply symptoms of reflux. And it's been suggested that for every 5-point rise in BMI, there might be about approximately a 3-unit rise in the Demister composite score. We know that the BMI category applies to both genders, both female and male, and again, the data down the bottom from Corley suggests that the higher the weight or the higher the BMI, the greater the likelihood of reflux. We also, of course, know that anti-reflux surgery, fundoplication in particular, is a good treatment for reflux. For many years, we've known that heartburn and regurgitation, the typical symptoms of reflux, but also some of the atypical symptoms are likely to improve after anti-reflux surgery. And indeed, on the right-hand side, for a few years now, we're very clear that surgery is a very good option, which we all know about, and it's superior at least in certain groups, to active medical treatment or conservative management. However, despite fundoplication being very good, BMI decreases the outcome or worsens the outcome of surgery. Recurrences of reflux, both symptomatic and objective, are higher in the obese population. When you look at recurrence in that graph or the table on the left-hand side, we can see that the overweight people are much more likely to have a recurrence, and that doesn't apply solely to a particular operation. It applies to both laparoscopic Nissens and partial fundoplications, as well as some of the other types of procedures as well. I've selected one article for this, but there's a large volume of literature which should support higher recurrence rates in the obese, presumably because of higher intragastric pressures and the precursors to reflux not being addressed, and therefore the fundoplication is unlikely to be as good. But certainly recurrent paraesophageal hernias are more common in the obese population. There is, however, some data that suggests that's not the case. So, for example, this paper in 2005, a bit old now, suggests very good outcomes in the obese population with fundoplication, and there is some supporting data in the literature for the alternative view. So it's not crystal clear, but probably in many people, the higher the BMI, the higher the chance of reflux recurrence. We do have alternatives, of course. For example, the Roux gastric bypass, as you will know, the acid-producing cells of the distal stomach are sort of rerouted, so they're a metre and a half downstream from the LES, decreasing the amount of acid that's available to reflux back up, but also the significant weight loss that comes with bariatric surgery. Roux gastric bypass decreases intra-abdominal pressure and decreases the cause of reflux in many of these patients. Additionally, Roux gastric bypass and other bariatric operations, of course, have all the added benefits of bariatric surgery on cardiovascular and metabolic health. So there are benefits in this operation more than just the reflux control. So maybe we should treat the GERD and the obesity together. And there's certainly lots of data to support this. That graph up the top, or the table up the top, shows the change in gastroesophageal reflux symptoms after gastric bypass. And we can see that just about all the symptoms will improve, certainly the typical symptoms of reflux, but the atypical ones can improve as well. And again, there's multiple papers in the literature which would support that position. And down the bottom, we can see that the response is durable. The response to gastric bypass surgery in the obese population, as expected, will decrease acid exposure to the lower esophagus and the symptoms that go with it. How does it compare to simple anti-reflux surgery? The graph on the left will show gastric bypass compared to laparoscopic Nissen fundoplication, both with Demister scores, composite scores, as well as symptoms. And it looks equivalent, or probably a little bit better in some of the obese populations. Again, this is only a single paper, but multiple papers would show equivalence in reflux control. On the right-hand side, we can see, of course, gastric bypass compared to one of the more common bariatric operations, the laparoscopic sleeve gastrectomy, and this is where it becomes a bit more controversial. But certainly there is some data that gastric bypass is significantly better than sleeve gastrectomy, of course, in the reflux patients. So multiple people have looked at this, and there are guidelines that we can refer to. The SAGES 4GARD Task Force published a white paper a few years back now, and quite rightly, they commented that the literature on sleeve versus gastric bypass in the setting of GERD as a bariatric procedure with the aim of weight loss is ambiguous because there is the conflicting data. But studies appear to favour gastric bypass as the weight loss procedure of choice for patients with pathologic GERD. And that probably stands still a few years later. There was noted to be inadequate data on the ideal workup of a patient with GERD prior to weight loss surgery. So again, the target of this was weight loss surgery, and that's particularly pertinent in the patients who desire a sleeve gastrectomy. Of course, the risk profile of a gastric bypass operation for obesity is very different to the risk profile for a sleeve gastrectomy. Sleeve gastrectomy has lower both perioperative and long-term risk, but there are obviously benefits long-term as well. So some patients do want a sleeve, and certainly in my practice, patients are pretty clear on what they want when they come in, and the workup was unclear to this task force about what to do for those patients. ISDE looked at it more from a reflux point of view, and for patients actually with reflux symptoms, both typical and atypical, they tried to answer the question that was missing in the SAGES 4GARD task force, and suggested that proper formal testing, objective testing for reflux be performed in patients who are significantly considering the sleeve gastrectomy. It might be able to push them over the line towards the sleeve, but otherwise gastric bypass would be very reasonable. I'm not going to be complete in this talk. There are obviously other options. There's multiple papers throughout the literature, and many of you in the audience will have performed sleeve gastrectomy in refluxes with or without fundoplication above it, with minimizer rings and other prosthetic devices. Magnetic sphincter augmentation in its various positions and accompanying various operations has certainly been published. And single anastomosis gastric bypass, though, can still suffer from particularly biliary reflux. Certainly has been used for patients with reflux. Guidelines, particularly on this topic, therefore, there's three major papers that I know of. The AGA came up with saying that with proven reflux, gastric bypass is an effective anti-reflux operation, and it should be the procedure of choice, particularly when compared to sleeve gastrectomy, and I think that's very reasonable. The 4GARD task force again said that gastric bypass should be the gold standard approach to symptoms of reflux in a refluxing population who's obese, greater than a BMI of 35 they chose. And there are papers that suggest 35 or higher. And the SAGES multi-societal GERD guidelines, which were recently published by Dr. Slater, have suggested that patients with medically refractory GERD and high BMI may benefit from either, and it was a conditional recommendation, and those of you who know the grade process, that sort of allows discussion between the patient and the physician, though the certainty of evidence was very low. So my thoughts on the matter, really never push a patient into a bariatric operation. If they're coming to you for reflux, you want to treat their reflux, and if they feel like they're getting pushed into, say, a gastric bypass, things get very difficult very quickly. Treat the presenting symptom. They've come in with a problem. They're either worried about their weight or they're worried about reflux, and what you really need to treat is what they're worried about, with advice and education to guide them in the right direction. If their major presenting complaint is reflux, I think we can discuss the options of fundoplication versus gastric bypass, but strongly suggest that for the higher BMI patients, the gastric bypass would give them the added benefit of both anti-reflux effects, but also of the benefits of long-term sustained weight loss. If they're coming in for obesity treatment itself, I think it's a bit easier. I think that if they've got significant symptoms of reflux, do not do a sleeve gastrectomy. It'll cause problems. If they really, really want a sleeve, and that's what they've done their research and all their friends have had that one and that's what they want, then perhaps there's a role for preoperative testing to try and rule out reflux in the patients with the symptoms thereof but not objective evidence. I think that's a very small group, and caution would be advised. Thank you very much.